Privilege for me to be here and presenting a topic on the novel clusters of diabetes and the treatment challenges. So let me extend my sincere thanks to Jyotidev sir for this fantastic opportunity. So I will just start my presentation from a case which I happened to see a couple of weeks back. This is a patient who came, he is a 25-year-old patient. He came with very high blood sugars. So are we dealing with a straightforward case of a diabetes? So what happens to this patient we will see during the talk, and what is this patient all about. Now all of us know diabetes is growing in epidemic proportions, and we had to treat so many diabetic complications. So the awareness of diabetes and its complications and various aspects, all of us should be well equipped with. Now, if you look at the current classification of diabetes, now all of us know there are four main types: type 1 diabetes, type 2 diabetes, the other specific diabetes which includes the body, then there is gestational diabetes. But diabetes, if you look, it's a continuum. At one end of the spectrum, you happen to see an autoimmune predominant diabetes, and the other end of the spectrum, a metabolic dysfunction predominant type 2 diabetes. And in between, you will happen to see so many different types, like MODY is there, LADA is there, and various amounts of insulin resistance and deficiency happens in these patients. So whatever is the type of the patient, the ultimate the main culprit is the dysfunctional beta cell. That is the main culprit of all these things. Now, if you look at the current classification and diabetes management, we see the patient as a type 1 diabetes, type 2 diabetic, then we manage as per the guidelines, one size fits all. That's what we are doing most of the days. But what we need to understand is type 2 diabetes and type 1 diabetes is a polygenic diabetes. This is a very, very important factor. And if you look at the type 2 diabetes, it's a truly heterogeneous disease. Truly heterogeneous in the sense, phenotypically it is different, genotypically all the patients are different. The phenotypic, genotypic aspect, everything is different. And the conventional way, if you look, these type 2 diabetic patients will be having various amounts of insulin resistance and insulin deficiency. Clinically also, we can make out clinically whether the patient is having a predominant insulin resistance or deficiency. Insulin resistance, if it is predominating, the patient will be in an anabolic state, weight gain, central adiposity, fatty liver. And when you see insulin deficient patients, you can see more often the catabolic state, weight loss, the three P's, the polyuria, polydipsia, polyphagia, the weight fatigue, the diabetic ketoacidosis. So by just looking at the patient, we can make an understanding whether the patient is having a predominant insulin resistance or insulin deficiency. So keeping this in mind, from the last couple of years, scientists all over the world have tried to see this in a various aspect and tried to cluster the type 2 diabetic patients into different subgroups based on the varying aspects of insulin resistance and insulin deficiency. So this is nothing but classify patients based on the clinical aspects, the lifestyle, the biochemical markers, the management, all these based on the complications. The type 2 diabetic patients are classified into different subgroups and they are given management. So the main concept is the right treatment is given to the right patient. That is, in fact, we are inching towards the precision medicine. So there are several goals of clustering of these diabetic patients, predominantly concerned with prognostication, preventing the complications, and the management aspects. So there has been a lot of literature evidence, if you look, regarding the clustering of these diabetic patients. This is a standout research article which came way back in 5 or 6 years back. This is from the LEAF group from Sweden. And they actually try to do the data-driven cluster analysis of type 2 diabetic patients. And this clustering was basically done on the basis of 8 parameters: the GAD antibody, age, BMI, HbA1c, and the HOMA beta cell, HOMA beta and HOMA insulin IR. Based on these parameters, the type 2 diabetic patients were clustered into different groups. 5 important groups of type 2 diabetic patients were being clustered. You can see the first one, that is severe autoimmune deficient diabetes. It is just like a type 1 diabetes. The rest 4 types are type 2 diabetics, like the severe insulin deficiency diabetes, severe insulin resistant diabetes, mild obesity related diabetes, and MARD, that is mild age related diabetes. So these are varying forms of type 2 diabetes which are being clustered based on the insulin deficiency and insulin resistance. So the importance of this clustering, that we could make several inputs. We could get several inputs based on these clusters regarding the prognosis, regarding the management aspects, regarding the complications, what the patient is going to have. And the severe insulin deficiency patients were found to have more of diabetic retinopathy, and the severe insulin resistant patients were having more of diabetic kidney disease and coronary artery disease. So what about these clusters in India? So this just came 5 or 6 years back. So what is the Indian phenotype? Now all of us know the Indians have a very, very different type of phenotype. We have the diabetes occurs 1 decade earlier, the heart disease hits 1 decade earlier, we have a thin fat Indian type, the metabolic parameters are different, the BMI pattern is different, the low level of adiponectin, and the characteristic diabetic dyslipidemia, the increased small dense LDL and reduced HDL. All these are characteristic of Indian phenotype of diabetic patients. Now based on this, the Mohan group from Chennai, they collaborated with the Scotland, the Dundee University from Scotland, and they did a study known as the INSPIRED study, and this included around 20,000 patients, and they did clustering based on these 8 parameters. Rather than the HOMA, they took the serum C-peptide levels, both fasting and stimulated, and they clustered and they found out these 4 important clusters. The first one is basically similar to the severe insulin deficiency, and the last one, the age-related diabetes. Both these were similar clusters to that seen in the Sweden study. But the middle part, what you see, the 2 important novel clusters, the insulin resistance obese diabetes and combined insulin resistance and deficiency diabetes. These 2 clusters were novel, which was not seen in the Sweden study. So if you look at closely the parameters, you can see the BMI part, the insulin levels, the C-peptide levels, all these are very, very important, and they could find out these 2 clusters are very, very peculiar to Indian subgroup of patients. What these Mohan and the collaborators did with, they actually validated this study by incorporating it in the ICMR INDAB study so that they could study across the nation a huge amount of population based. They made it a population study, and because it is a population study, they excluded the C-peptide level, and they looked at the 6 parameters which are shown in the bottom. And to the surprise, they could replicate the evidence which was got in the previous trial. The clusters were almost similar. They could identify the 2 novel subgroups, the insulin resistance obese diabetes and the combined insulin resistance and deficiency diabetes. They could replicate this in their study also. The most important take-home message of this trial is relating to the complications. The insulin deficiency group had an increased incidence of retinopathy, while the combined insulin resistance and deficiency had all these things, increased evidence of retinopathy, nephropathy, and chronic kidney disease. So I just tried, regarding the management also, all of us know the deficiency will be very difficult to manage. Insulin resistance, again, we can manage, but the combined insulin resistance and deficiency comes in between these 2 forms. And in fact, I tried to, whether we can see such patients in my clinical practice also. This is, again, a 29-year-old patient, the characteristic one which we see, obese type of diabetes, and he came with very high blood sugars. He had family history of diabetes. He had all the features of metabolic syndrome. And look at the fasting serum C-peptide. It was to the tune of 8.2. So he was diagnosed as an early type 2 diabetes. The next person which I showed in my first slide, this is a 25-year-old patient, obese. He had metabolic syndrome. The characteristic dyslipidemia, you see the triglyceride is very, very high, 616. The HDL is low. He has features of metabolic syndrome, but look at the fasting serum C-peptide. His serum C-peptide on diagnosis is 0.9. So we have two patients, early onset diabetes. Both of them are in 20s, mid-20s. One has got a very high fasting serum C-peptide, one has got a very low serum C-peptide. So the second one is a combined insulin resistance and deficiency diabetes, and according to the data, we can clearly say that this patient is having a very high risk of complications later on. So there is so many articles, if you look, regarding this unique novel clusters and their pattern of involvement and all those things. You can see this is a worth reading article, another article. So the most important thing is we should understand that the insulin resistance and insulin deficiency occur in a patient in varying amount. We need to understand that and act accordingly. If the insulin deficiency is predominating, we need to address that and give drugs according to that. And if the insulin resistance is predominating, we need to address that and give drugs giving those aspects. So this is a chart which clearly shows if the patient has got an insulin deficiency, the autoimmune predominant, we may have to start insulin very early. No need to go for further drugs. Then late onset diabetes, maybe the gliptins, biguanides, and in patients who are having a predominant insulin resistance, the drugs like the weight loss drugs, SGLT2, thiazole, the GLP-1 receptor agonist, biguanides, all these are really handy in this group of drugs. So based on this, we have seen the advantages of clustering. We can subclassify the type 2 diabetes into different subtypes. We can think about the prognosis, the complication levels, and what the patient is going to have in future, and we can give a precise management for each subclass. Now, if you look, there are so many apps available right now. This is one app, Diana app. We can give the various variables, feed the various patterns, and this app will give you what type of subclassification the patient is having, and they even suggest the treatment possibilities also. So these are the various things which I tried to find out in my clinic, that whether we are also getting these different types of patients. This is a patient who is LADA. She was diagnosed at the age of around 30s, mid-30s, and this is almost similar to the severe autoimmune insulin deficient diabetes. That is, GAD antibody will be positive, and C-peptide will also be there. So it is just like a LADA. Another patient is just like clinical features of MODY. Family history is there, C-peptide is there to some extent, and this is almost like a severe insulin deficiency diabetes. C-peptide is on the lower side. Then another very young patient, one of our staff's son, he also very early onset of type 2 diabetes, typical insulin-resistant obese diabetes. He has almost all the features of metabolic syndrome, and he is only 18 years of age with features of insulin resistance. And then the last patient, which I have very clearly described, the combined insulin resistance and deficiency diabetes. This patient has features of both insulin resistance and feature of insulin deficiency. Why insulin deficiency is because at the diagnosis is fasting serum C-peptide is very much reduced, and this patient is highly liable for various complications. So just summarize what I was trying to convey in the last 12-13 minutes. Type 2 diabetes is a truly heterogeneous disease. We need to understand that. All patients cannot be taken in a similar manner. Varying amounts of insulin resistance and insulin deficiency occur in a patient. We need to understand that very clearly, and then we need to address that. If the resistance is predominating, we need to address that. If the insulin deficiency is predominating, we need to address that. There is traditional classification of diabetes, all the traditional one which we have heard. And now the cluster-based classification of type 2 diabetes has gained importance in the last couple of years. The cluster-based classification is based on the phenotypes and the pathophysiology. The pathophysiology is given absolutely great importance in this group of patients. Clusters in Indian context also I have told. Indians are totally different. They have a different Indian phenotype. Their phenotypical nature is different, the genotype is different. So we need to understand, we cannot equate an Indian patient from a Western patient. these patients should be treated as unique, and we need to see those patients and treat them. So clustering is always important because we can identify the risk factors, we can prognosticate, and we can also manage these subgroup patients. And the most important part of clustering is the precision management. Nowadays, almost everywhere in the world is giving importance to precision medicine. So by doing a clustering, we are inching more towards precision medicine. Thank you.
Thank you, sir. I think you highlighted very clearly the whole aspect of, you highlighted very clearly the whole aspect of, how the challenges that we are facing with dealing with diabetes. I think from an Indian perspective, all of us have rural as well as, urban practices. And our patients come from far off places. So we don't have that luxury most of the time to kind of immediately, get this diagnosis. So it's after consequent visits because of the high level of suspicion, not the inability for us to achieve our glycemic targets. That's when we start to look at further. Have you seen, particularly in certain types of cases, especially when we talk about LADA, and there are cases where they don't come with acanthosis, but still the blood sugars are extremely high. Do you still see some classical signs that we can pick up on examination?
Very true, sir. LADA patient, especially patients coming in, these do come every now and then to our clinic, but most of them go unnoticed. That is the most sad part of the story. LADA patients usually come in early 30s. They are not obese. They will be having some amount of C-peptide to the tune of 2, maybe 3. And anti-GAD antibodies will be positive. How can we pick this? Because many times these patients may be having associated thyroiditis, autoimmune thyroiditis, vitiligo, lean patient. So these patients we need to pick, especially thyroiditis. It is Hashimoto's thyroiditis in that not obese type of patient, or any other autoimmune feature if we happen to see. I think it is always good if you can check an anti-GAD antibody and a C-peptide level. The importance of diagnosing is, if you happen to see a LADA patient, you don't give drugs like secretagogue for a long period of time. Try to start insulin as early as possible, and try to preserve whatever the residual beta cell function the patient is having.
Thank you, sir. This is one last point from my side. For us, I think now using the help of CGM, picking out the patterns in when we start the treatment, and then subsequently after achieving good glycemic control, whatever the pattern that remains, that gives us a clue that we need to further investigate. So do you feel like, again, CGM may not be an option for quite a lot of our patients. So that's where I do, extended SMBG for them. So it will be like 1 hour, 2 hour, 3 hour also. So there again, kind of to trace that pattern. So in insulin resistance, the pattern is different. In LADA, again, you'll get a sharp jump in blood sugar levels from baseline. So these things, so do you think that is also one more way? Because with just C-peptide as a marker for us, sometimes C-peptide can improve after we, when they come in a glucotoxic state, very high blood sugars initially. After we treat, then the C-peptide tends to improve after about 3-4 months when we repeat. So do you feel we can also look into these types of methods to kind of pick out these cases?
Yes, sir, absolutely. But regarding CGM's different pattern to differentiate between, I am not sure, sir. I don't have much but one thing we can say, that is why I have included one side very clearly. Clinically, we can identify patient whether the predominant whether it is insulin resistance or predominantly patient is having an insulin deficiency. Clinically, we always need to look that. And if possible, a C-peptide will hardly cost 600 rupees. There is no harm in doing a C-peptide and finding out what is the beta cell reserve the patient is having.
Sir, in the INSPIRE data by Professor V. Mogan, They did an observation data analysis regarding with the microvascular complications, sir. They found there is increase in the prevalence of both retinopathy and nephropathy, both in severe the SIRD and the CIRDD. Is there is any data regarding with the macrovascular complication, because they analyze only with the microvascular complications with this form, whether any analysis report or observation data over the macrovascular complications?
Sir, in fact, the final, the one which I showed, after they incorporated the data in the ICMR INDIAP study, in that actually the resistant group had more incidence of coronary artery disease also. That is there. Coronary artery disease also. Macrovascular complication is also there. Especially for the novel subgroups. Their complications are not limited to microvascular complications alone. They have both micro and macrovascular complications.
Thank you, sir.
Is there a genotype study on these 5 clusters?
Genotypically, sir, only the antibody.
All CIRD will have the same genotype, all the 5 will have the same genotype. You do a genotypic study. Is there any genotype data?
No, I am not aware of actually. The pathophysiological, the phenotypical is there, but genotypically it is very cumbersome, and also it's very costly. It is going to be very costly, sir. Because the last ICMR INDIAP data, it's almost 1 lakh population. It's a population study, the last one which I showed. So going for a high range studies, it will be rather very difficult.
It will be a precision.
Precision.
Your code is personalized.
Yes, yes.
There are certain studies which are happening, but I think 2 months back there was publication in UK.
We're only starting to do now genotype now, so it is a matter of time that we'll have that out there. So
one thing which we can say, the awareness has been tremendous, and the world everywhere now it is, awareness has picked up, and many are looking in this direction.
Thank you so much, Dr. Sunil, and if there are no further questions, we can move on to the next. Thank you.